Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar. This evening, what we're going to do is share with you an infant and neonate skincare algorithm developed by a group of experts. As speakers, we have Dr. Peter Leckman, who is the Medical Director, Pediatrics and International Health at Northwestern Medical Group, and Instructor of Clinical Pediatrics of Northwestern University Feinberg School of Medicine, and attending physician at the Anne and Robert Lurie Children's Hospital of Chicago. We also have as speaker tonight, who is going to go through this algorithm with you, Dr. Lauren Schachner, who is Professor and Chair Emeritus Dermatology, Director of the Division of Pediatric Dermatology, Professor, Department of Pediatrics, Leonard at M. Miller School of Medicine and University of Miami, and also the Chair of the Masters of Pediatrics, which I believe is in its 20th year. If you want to come and join us on February 11th and 12th in Miami Beach, Florida.
We'd like to thank our supporter, CeraVe, for making this educational event possible. Before we begin,
a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill out this very short survey. And finally, within 1 to 2 days of the webinar, the recording and a certificate of attendance will be emailed to you. Remember, please submit your questions using the question chat pane on the right-hand side of your screen, and I wrote a little note there so you can see where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Schachner.
Good evening. I'm delighted to be joining my colleague, Dr. Leckman, and you this evening to discuss a new algorithm which will help healthcare professionals care for the skin of neonates and infants. The neonatal and infant period is a very vulnerable period because it takes up to 2 to 4 years for the skin, especially the stratum corneum, the epidermis of the neonate and infant, to mature to adult function. Well, during that time, the skin needs a lot of support, the appropriate cleansers, the appropriate moisturizers, so that it can do the barrier function that this little 7-micron stratum corneum has to do to keep out allergens, bacteria, toxins, etc. So we're going to stress the best care of neonatal and infant skin. So the first polling question, all of the following are true except which one? Compared to adult skin, neonatal skin has. Pick the one that you think is not true. Well, pretty well done. The majority have felt that it's less transepidermal water loss because, in fact, that is one of the problems that the neonate has. They have excessive transepidermal water loss. So we're going to review challenges in newborn and infant skin barrier integrity and issues of sensitive skin. We're going to review the importance of ceramides in the newborn and infant skin, and we're going to present the algorithm that was published just last month. I'm really very fortunate. I got to work with several outstanding pediatric dermatologists, pediatricians, and basic researchers looking at the importance of skincare for neonates and infants and developing an algorithm. And as the conclusion says, the current algorithm focuses on neonatal and infant healthy skin that can benefit from skincare. When applied from birth onwards, gentle cleanses, and especially ceramide type moisturizers and moisturizers containing barrier lipids help maintain the protective skin barrier and skin barrier function. I worked with this group a year ago in developing a consensus statement about the importance of ceramide containing skincare for neonates and infants. And essentially, we reached a consensus of 8 statements. At birth, the skin is structurally and functionally immature, elevated skin surface pH, lower resistance to chemicals and pathogens, and of course, increased transepidermal water loss. The complete maturation process will take 2 to 4 years. The permeability barrier that the skin has is provided by intracellular lipid-enriched matrix with the 3 components of ceramides, free fatty acids, and cholesterol. The ceramides themselves are an important lipid found within the stratum corneum, contributing to the intracellular lipid layer and essential in the regulation of transepidermal water loss. If we have ceramide depletion, we may see several neonatal and infant skin problems, including atopic dermatitis, xerosis, and ichthyosis. So the skincare of newborns and infants has to be safe and effective, and to exclude agents that can negatively influence the skin barrier or induce systemic toxicity. Things like soap with their alkaline pH can be injurious. Baby skincare with ceramides mimics physiological lipids and actually supports the skin's own production of natural homeostasis. Daily use of moisturizers that contain humectants and ceramides have been shown to reduce the rate of atopic dermatitis flares, which is very important in mitigating the atopic march. And it reduces the need for the use of topical steroids, which is desirable. We'd like to reduce them, obviously, in neonates, infants, and children. Parents and caregivers need to understand how to avoid triggers and irritants, how to cleanse and hydrate the skin, how to apply moisturizers, how to use physiological skin cleansers and emollients with pHs in the 4 to 6 range, and to avoid the alkaline soaps with a pH up to 8 to 10. Skincare started shortly after birth may avoid or attenuate and mitigate skin damage inducing derm conditions, including ones we mentioned like atopic dermatitis, xerosis, ichthyosis. So at birth, the skin is structurally and functionally not fully developed, elevated pH, and lower resistance to chemicals and to pathogens. This was a study done in Asia looking at infants, comparing them to adults, and they showed a much higher rate of transepidermal water loss in the babies. And they showed that the stratum corneum was up to 30% thinner, as was the entire epidermis in the babies compared to the adults. Furthermore, there was increased case senolytic activity with that protein lysis. The result, increased desquamation and a thinner stratum corneum and challenges for the barrier function because proteins were part of the desquamation. This study out of Germany looked at electron microscopy to judge skin maturation. They looked at the stratum corneum, and here you could see that it took up to 24 months before the skin of a baby starts to approach the thickness of mature skin. The pH of neonatal skin at birth is typically more alkaline than it will be when the skin matures. It can be 6 to 7 or more. Why? The baby's been floating in alkaline amniotic fluid during the preborn life, so they're born with alkalinization. You need a slightly acidic skin surface to give you the acid mantle that defends the skin against infection and allows for commensal bacteria to populate the skin appropriately. So the process of skin acidification plays an important role in barrier maturation and the activation of enzymes involved in the extracellular processing of stratum corneum lipids. If we looked at the scorecard of structural and functional differences between infants and adults, we see the skin is thinner, has less cellular attachment, has a flat DE junction, all which would permit more absorption if we're not helping the skin be a good barrier. There are less lipids, less melanin, less sweat, less natural moisturizing factor, which balances the amount of hydration in the skin, and even the immune system. There's less cathelicidins, there's less defensin, so the child will be more infection prone. And while the microbiome is formed by similar organisms in the commensal bacteria, the concentrations are different. So lots of structural and functional differences. And when we put together a thinner stratum corneum, a lesser amount of lipid, a lesser amount of natural moisturizing factor, a higher pH, well, we're going to have issues of increased water loss and not competent control of hydration. We've said that the complete maturation process of the neonate skin takes from 2 to 4 years. In the utero, as the vernix caseoso forms, this naturally occurring biofilm will start covering the baby during that 3rd trimester, giving the baby a waterproofing in utero and also covering the baby's stratum corneum and epidermis during key periods of the last trimester when there's terminal differentiation of the epidermis and formation of the stratum corneum. So the vernix caseoso is kind of a hero. The ceramide-rich fetal coating formed during that last trimester with corneocytes embedded in lipids protect and waterproof the baby. So the baby does not come out born looking like a prude. The skin doesn't look too bad at all. And it protects the immature barrier function of the neonatal skin, to the point where it's been found that if you leave the vernix caseoso on for a few hours, a couple of hours, and some people let it on for a couple of days, it increases the hydration, the suppleness, and the plasticity of the stratum corneum. So a ceramide-rich vernix caseoso protects the baby not only in utero, but immediately after birth. This protective layer will decrease the skin surface pH, helping form an acid mantle, inhibit pathological bacteria growth, and facilitate commensal growth. Now, after birth, the permeability barrier of the skin is largely controlled by the intercellular lipid-enriched matrix made up of ceramides, fatty acids, and cholesterol. The ceramides are awfully important as a component of the stratum corneum. It contributes to the lipid bilayer, which regulates water loss and gives us healthier barrier function. We've seen a number of disorders where ceramide depletion is associated with skin issues, including atopic dermatitis. So in a healthy skin, we have in the epidermis the corneocytes surrounded by and into, we'll call it the mortar, in between the cells of the lipids made up of fatty acids, triglycerides, and also ceramides. And that allows the skin to function. If we had a close-up, we would see that the skin is covered by a lipid envelope and that the corneocytes themselves have a matrix in between them that we call the lipid bilayer. So we could make an analogy to say the corneocytes are the bricks and the mortar is made up of the lipid lamella, which encases the corneocytes, preventing water loss and controlling permeability. These are crucial elements of the epidermal barrier. The composition of lipids changes from the time the baby's born. There is a good concentration of ceramides, but it actually increases as the skin matures, and the ceramides play their important role in the maturation and in control of the hydration and barrier function. If there is an endogenous decrease in ceramides, you can see a number of disorders. Without the proper ratio of ceramides, the stratum corneum becomes less competent. And with impaired synthesis of these essential lipids, including ceramides, cholesterol, and fatty acid, you have impaired barrier homeostasis, dryness, irritation, erythema, and itching. So we can see this ichthyotic looking skin, this sclerotic skin, and this beginning of eczematous atopic dermatitis skin with decrease in ceramides. This was a really interesting study done in Great Britain in which they measured transepidermal water loss within the first 48 hours of life and followed the babies for 6 months. They found at the end of 6 months that about 19% of the babies presented with atopic dermatitis. There was a statistical significant relationship between increased transepidermal water loss at 2 days and atopic dermatitis at 6 months. The researchers concluded that impairment of skin barrier function at birth and at 2 months was shown to precede and predict clinical atopic dermatitis. Likewise, those with increased transepidermal water loss, interestingly, appeared to have a greater likelihood of food allergies at several years of age. They concluded that early intervention with the liberal use of emollients might prevent or attenuate atopic dermatitis. And why is that important? It's important because early onset atopic dermatitis, if there is very early onset, if there are more severe flares and a higher number of flares, especially with a family history, then you are going to be much more likely to see the atopic march in which an eczematous kid goes on to have reactive airway disease, wheezing, asthma, sinus problems, polyps in their nose, food, etc., allergies, etc. If we could attenuate the number and severity of these flares, we are much more likely to get a healthy child, an adolescent. So it's very important to attenuate the number and severity of flares and mitigate the atopic march. Daily uses of moisturizers that contain humectants and ceramides reduce the rate of atopic flares and reduce the need for topical steroid treatment. And this was one of the very important consensus statements made by this group. Skincare started shortly after birth may avoid skin damage inducing derm conditions and attenuate the severity of conditions such as atopic dermatitis that can go on to be associated with overall well-being. You don't want a situation in which the lipids are gone because you're going to have a less functional barrier and allergens are going to be able to get in through a less functional barrier down to where immune cells, antigen processing cells, and the beginning of severe inflammation will take place. You need the lipid barrier to prevent that from happening and to allow the skin to fight off the allergens, the toxins, the bacteria out there in the world. Prophylactic use of emollients was discussed in a very important paper in the Journal of American Academy of Dermatology, which talked about a consensus on atopic treatment and the use of emollients prophylactically, it was stated, can control transepidermal water loss, restore skin elasticity, restore skin barrier function, and may prevent progression to atopic dermatitis flares. And atopic dermatitis guidelines, which this paper presented, support moisturizer use. Evidence-based guidelines for atopic dermatitis support the use of moisturization and moisturizers for skin hydration and for atopic dermatitis symptom improvement. The guidelines recommended moisturizers be used as a primary treatment for mild disease and in conjunction with other agents for moderate and severe disease. But if found in mild disease, moisturization emollients could be the primary treatment. Looking at this from another point of view, and our colleague here does have an interesting point of view, moisturization in atopic dermatitis through the years has been shown to decrease steroid use in atopic populations, reduce the pruritus on its own, which is obviously the bane of many atopic patients' existence, reduces all the measurement tools we have, SCORAD, EASY, IGA, just by constant moisturization, improves quality of life, reduces the number of flares, hence increases the time to flare, thusly decreasing likelihood of the atopic march, and may help decrease progression of AD in atopic-prone newborns. It can also play a role in reducing contact dermatitis. How come newborns don't have atopic dermatitis? What blocks them from happening? I think we give a lot of credit to the Vernix caseoso and the original ceramide, first seen 200,000 years ago when the first human baby was born, because that protects the fetus and early neonatal skin from the signs of atopic dermatitis. Moisturizer use to improve the skin condition. Interesting paper early on. This was the first of a series. Not the best known paper, but actually the first, came out of Scandinavia. They looked at 56 6-week-old kids with cirrhosis. A number of them got oil baths and facial moisturizers, a number didn't. 3/4 of those who did get moisturization, despite the cirrhosis of 6 weeks, had normal skin at 6 months. Only 37% of the group that didn't get moisturization, thusly the majority, 63%, did not have normal skin and did have atopic findings. So this group felt that regular oil baths in infants seemed to reduce cirrhosis and possibly the emergence of atopic dermatitis. The next study we're going to look at was a study in the US and the UK, over 120 kids. These were considered high-risk infants because siblings or parents had atopic dermatitis. Emollients were started in half the group by 3 weeks of age, and at 6 weeks of age, 43% of the non-emollient treated group had atopic dermatitis versus 22% of the emollient group. It felt that the relative risk reduction of the atopic dermatitis showing up by 6 months was reduced 50%. Nice work done by Eric Simpson, and simultaneously to that, a paper out of the Japanese literature looked at almost 120 children in a similar situations, and they found that 40% in the control group developed atopic dermatitis as opposed to 32% in the emollient group. And so they felt, again, that they were at least mitigating for this first months of life the development of atopic dermatitis. Now, several subsequent studies have not confirmed prevention of atopic dermatitis in newborns with the use of emollients, not to the number that these studies by Mackay and Simpson showed, but they do confirm often, many of these studies, that there's a decrease in atopic flares, which of course would be beneficial in avoiding the progression to the atopic march. So there is terrific degree of importance of decisions we make in the skincare of our newborns and infants. And Dr. Leckman is going to move forward with a discussion and show you the algorithm that the group decided on. I think you're going to find it very interesting. But to summarize, gentle cleanses and application of physiological lipids can improve skin barrier homeostasis in newborns and infants. Early skin care may be beneficial to common dermatological conditions, such as an attenuation of atopic dermatitis and flares. Daily use of moisturizers contain humectants, moisture-holding substances, and ceramides decrease the number of flares and, fortunately, reduce the need for topical steroid treatment in a population where we would like to minimize the use of topical steroids. At this point, it's my pleasure to turn the floor over to my colleague, Dr. Peter Leckman.
Hi, good evening. Thank you, Dr. Schachner, for a wonderful presentation so far. I'll try to follow in Dr. Schachner's footsteps. As it was mentioned, I'm a general pediatrician. I've always had an interest in pediatric dermatology, and it's kind of been an honor for me to work with Dr. Schachner and the other pediatricians, peds derms, and dermatologists on this journey towards developing an algorithm. And I can say, as a general pediatrician, what I've learned during this process and the outcome of this process has really informed and changed and improved my approach towards infants with regard to their skin, towards my approach to atopic dermatitis, and has helped me, allowed me to help educate my patients to do, I think, a better job in promoting good skin care in infants and children. So, polling question. So the question is, all of the following tips promote good infant skin care except for one of the following: bathing daily or every other day, to bathe using a gentle cleanser with a physiologic pH, to apply moisturizer 1 or more times per day, keep room temperature on the cooler side, 70 degrees or lower, and using soft fleece infant clothing. So as you can see, we have a little bit of a dispersion of results. And the one tip that we recommend is to not use soft fleece infant clothing. So fleece warms the baby up a lot and actually promotes perspiration. And as the babies perspire and get hot, that actually can exacerbate the dryness of the skin and exacerbate atopic dermatitis. And the second polling question. Oops. So sorry, we don't have a second polling question.
I think it's further down, Dr. Leckman.
Is it? Okay. Well, let's kind of march through the slides in the order in which we have them, and then if we have another polling question, we'll address it at that point. So the question is, why is it so important to keep the skin barrier well functioning? And the answer is that compromised skin barrier is susceptible to one of the reasons is that a compromised skin barrier is susceptible to toxicity. A compromised skin barrier is susceptible to toxicity through the skin may be seen in up to 25% of infants and young children. Increased vulnerability is secondary to increased body surface area to weight ratio, the globular child that Dr. Schechner describes, taking into consideration that full maturity of the epidermis may take 1 to 3 years or even longer. Depending on how much of a toxin has been absorbed systemically, topical agents that are harmless in adults can cause issues in children. These issues, although rare, can include hemoglobinemia, respiratory distress, neurologic toxicity, and even death in neonates and infants. And there are a number of agents that can cause this, and among others, these include isopropanol, benzocaine, pyrethrin, hexachlorophene, lindane, fentanyl patches, salicylic acid. And the use of common topical agents such as lindane and salicylic acid can lead to systemic toxicity in neonates and young infants, especially in those with skin diseases with impaired skin barriers. So as we've heard a few times already, ceramides play an important role in skin barrier integrity. Without the proper ratio of ceramides, the skin's barrier can become compromised, leading to dryness, irritation, erythema, and itching. And exposure to hot water, cleansers with an alkali pH, certain chemicals and other environmental factors may also contribute to skin barrier damage. So we talked about pH. So what happens when the stratum corneum pH is alkali? It's above 6, whereas a physiologic skin surface pH is between 4 and 6. The consequences of this elevated pH include inflammation, so increased inflammation, decrease in stratum corneum cohesion, and a decreased permeability barrier. So the upshot is that keeping the pH within normal values results in a more physiologic microbiome, repair of the barrier, increased epidermal differentiation, and reduced inflammation. So what sort of cleansers should we use in children? We've heard a little bit about cleansers. And if you look at this list of different cleansers on the chart, you can see that we include soaps, which tend to be very alkaline. Syndet bars or synthetic detergents in small amounts of soap, those bring us down more towards a physiologic pH between 4 and 6. Combined bars, which have equal parts soap mixed with synthetic detergent, also very alkaline. Liquid cleansers, a little better, but still a little bit alkaline at 6 to 7 pH. A non-greasy cleanser, so a synthetic cleanser that may contain ceramides, that gets you into 5 to 7 range. And then cleansers that include or employ a multivesicular emulsion system-based, a multivesicular system in order to deliver the moisturizer, and includes ceramides, which have a pH between 4 and 6 in the physiologic range. And we'll talk about that more in the next slides. So we came up with this idea, and a little bit of this seems, self-evident, but our group wanted to define, what the ideal moisturizer should have. So obviously it should be safe. Obviously it should be effective. As we just discussed, it should be of a pH that is near physiologic levels. It should be additive free. It should be fragrance free. It should be sensitizing agent free. It should optimize lipid and water content of the stratum corneum. And this one is a little bit of a funny one when you first hear it. It should be pleasant to use, but actually that's very important. If it's pleasant to use, if it feels good to the caregiver and feels good to the infant or child, it's more likely to be used and used properly and used with appropriate frequency. So again, we emphasize moisturizers containing ceramides. And just as a fine point, there are 9 different ceramides labeled 1 through 9, and CeraVe contains ceramides 1, 3, and 6-11. So speaking specifically about CeraVe and about the components of their products and the technology within their products, if we look at the left column, all of the ceramide products have ingredients that are integral to formulation that benefit the skin barrier. That's the whole point. They all include ceramides. They're all fragrant free. They're all non-irritating and gentle on the skin. They're all hypoallergenic and all non-comedogenic. Most of them contain hyaluronic acid and employ the MVE, or the multivesicular emulsion technology, which we'll speak more to in a moment. And on a limited basis, they might include parabens, sulfates, endocrine disruptors, dyes, propylene glycol, and mineral nut and coconut oil. So we try to limit those in our products or in the products that we use. So we talked about MVE, or multivesicular emulsion system. So this is a patented system that is employed in the CeraVe products in order to progressively release moisturizing ingredients versus kind of a quick burst of a traditional emulsion. So the graphic, I think, kind of says it all. I think of it as kind of the everlasting gobstopper of moisturizers, where you have the product, the moisturizer, that slowly, layer by layer, is released into the skin, so that it's released over time as opposed to being released all at once and then being done. And you can see in the graphic below, more conventional releases, you put the moisturizer on, it goes in, and then you're done, as opposed to the upper graphic where it's being released on a continual basis for a more sustained moisturization of the skin. Apologize, there's a little bit of a lag in the slides. So we will talk a little bit about this paper, the investigation of skin barrier restoring effects of a cream and lotion containing ceramides in an MVE, multivesicular emulsion, in people with dry eczema-prone skin. This is the Restore study, and in phase 1 of the study, you can basically see the print is a little bit small, but here's CeraVe cream, here are other creams that are applied. And the upshot is, going to the bottom left, in contrast to traditional emollients requiring regular application 3 to 4 times a day, the test products employing the MVE technology imparted sustained moisturization lasting more than 24 hours. So that reduces the number of applications required, reduces the burden of trying to provide good dry skin management. And as we all know, it's easy to do something once. It gets harder the more frequently you have to do it. There's also phase 2 of the Restore trial. And in this trial, it showed that CeraVe delivers barrier reinforcement compared to sort of standard paraffin-based emollients. That means they increase skin hydration and water content, they decreased skin dryness, they increased protection from irritants. And basically, they found that CeraVe is more cosmetically acceptable than the traditional paraffin-based emollient. And I apologize, go back a slide. So here's a paper by Dr. Andreessen, the CeraVe clinical study on adults and children with atopic dermatitis. And the point was to evaluate safety and efficacy of 6 weeks of CeraVe hydrating cleanser, followed by CeraVe moisturizing cream twice a day in both pediatric and adult studies. And you can see, so this cohort study on ceramide containing cleanser and moisturizer used for atopic dermatitis. This was in a group of pediatric patients less than 12 years old. You don't have to really we don't have to get into the details of this today, but basically there was much less, there's an improvement in measurable parameters, including irritation, pain, general skin condition in the cohort, in the pediatric cohort. So the conclusions from the trial, the trials, the skin of neonates and infants exhibits distinct anatomical and functional properties that might result in barrier dysfunction. Infant skin functionally is still developing, as indicated by elevated transepidermal water loss, skin surface pH values, and elevated desquamation. And neonates, in the fact is that in neonates and infant skin is more fragile and more susceptible to infections, chemical, and thermal damage. Continuing on, skincare for neonates and infants should be safe, effective in fragrance, as well as sensitizing agent free. It should be pleasant to use, containing ingredients that benefit the lipid and water content of the stratum corneum, such as those products containing ceramides. Several studies have shown that skincare, including specific cleansers and moisturizers, can reduce the risk of atopic dermatitis in atopic dermatitis prone newborns. But more robust studies are needed to confirm the perceived benefits of skincare in neonates and infants. So an article was published in the Journal of Drugs and Dermatology, and you can see that the lead author is Dr. Schechner and a group of fantastic pediatric dermatologists, and then one pediatrician, myself, as well as other pediatricians, were involved in putting together this article on an algorithm for skincare in neonates. So how did we go about creating this algorithm? This was a consensus process that we went through. So step one was to create a consensus paper. And then step two was the actual algorithm development. So there was definition of the project and selection of the panel, a lit review and preparation of the data and the algorithm, Then we had a panel Zoom meeting. Remember, this was all happening during the pandemic, at the beginnings of the pandemic. So we had a panel Zoom meeting to design an algorithm addressing neonates and infant skincare. We discussed the algorithm, adapted it, agreed on the version that would be used for the manuscript. And then we used an online procedure to reach consensus through blinded voting to define the final algorithm. And then we produced the final product and submitted it for publication. So a very extensive literature review was employed, and we won't bore you with all the details, but there are criteria used in the lit review. So we looked at literature describing current best practices in newborn and infant skin barrier function, and the use of ceramides containing over-the-counter skincare was identified in searches prior to the panel meeting. And then the selected literature is clinically relevant to newborn and infant skincare. It addressed various aspects of skin and barrier function. Prevention, efficacy, and safety of skincare use was addressed. And the ease of use, handling, and comfort of the skincare regime was analyzed. So the results of this lit search, which focused on stratum corneum barrier and ceramides in the English language literature from 2010 to 2020, there were 106 articles initially selected, 47 were included of those, and 59 were included in our project. 23 of those were clinical studies, 36 were reviews, and you can see at the very bottom, 15 clinical studies, 8 randomized controlled trials were used. So the summary of the literature review is summarized in the following. The skin of neonates and infants exhibits distinct anatomical and functional properties that might be clinically reflected by its susceptibility to skin barrier dysfunction. Infant skin functionally is still developing, as indicated by elevated transepidermal water loss, skin surface pH values, and elevated desquamation. In infants, in neonatal skin is more fragile and susceptible to infections, chemical, and thermal damage. You can see a theme here. Continuing the summary of the lit review, skincare for neonates and infants should be safe, effective, and fragrance-free, as well as sensitizing agent-free. It should be pleasant to use, containing ingredients that benefit the lipid and water content of the stratum corneum, such as those products containing ceramides. Several early studies have shown that skincare, including appropriate cleansers and moisturizers, can reduce the risk of atopic dermatitis in atopic dermatitis-prone newborns. Now, other studies do disagree, and more robust studies are needed to confirm the perceived benefits of skincare in neonates and infants. So here's the algorithm. In the middle, in the top row, you can see skincare for all neonates and infants, and we've included our skincare tips, which include full body moisturization after bath. Ceramide-containing moisturizations are preferred. 5-minute lukewarm baths with a gentle cleanser with a skin pH in the 4 to 6 range. Avoidance of irritating ingredients and agents. And for atopic, parents keep the environment cool and use soft cotton clothing. So we have skincare for all neonates and infants. They're broken up into 3 tranches or 3 groups. Infants with xerosis and scaling, infants and children with erythema, infants and children with erosion and blistering. And if we start out in the left most 2 columns of under xerosis and scaling with mild and moderate with mild to moderate white flaking skin, we care for it with moisturization. And dry the areas more frequently, consider using a cream or a lotion. If it's more moderate to severe with thickened scales, we would refer to dermatology. In the erythema columns, if there's visible erythema but less than 10% of the body surface area, we give condition-specific management, increase moisturizer. But if the visible erythema is greater than or equal to 10% of the body surface area, we would refer to dermatology. And then with regard to erosion blistering in the right-hand two columns, if we're having those issues in smaller localized areas, again, condition and specific management. But if it's extensive, we would like to refer to dermatology. And then we look for improvement, and if we're not improving, refer to derm. If we are improving, we continue treatment until clear. So I wanted to talk about the neonatal skin condition score. It's similarly broken up into three categories: dryness, erythema, and breakdown, where you get a score of a 1, 2, or 3, 1 being normal. Under dryness, normal, no signs of dry skin; 2, dry skin with visible scaling; 3, dry skin with cracking and fissures present. With erythema, no evidence, versus visible erythema in less than 50% of body surface area. 3, you get a score of 3 with visible erythema greater than 50% of body surface area. And if there's skin breakdown, again, you get a score of 1, 2, or 3 based on whether or not there's none evidence, smaller localized areas, or if there's extensive breakdown. And so a perfect score is 3 and the worst score is 9. And the relevant medical team should be notified if a neonate scores a single score of 3 in one area or a combined score of 6 and above total. In a dermatology referral might be appropriate at that point. So of all this work, we generated, as I mentioned before, skincare tips. And these are the things that really have helped me in providing skincare as a general pediatrician. So bathing daily or every other day, this is often a surprise to parents who historically have been told and are still told often in neonatal care units or in the nursery to bathe less frequently. We want to use a gentle cleanser with a physiologic pH, as we mentioned before. Moisturization is important after bath time. So apply head to toe moisturizer after a bath, once daily for all infants, and more frequently for those who have dryness, fissures, or flaking. And again, this is in contrast to what many parents hear in the newborn nursery even now. You want to maintain good hygiene. You want to have one baby-specific container, and you want to use a single-use applicator so that you're not introducing pathogens or somehow contaminating the container by going back to the baby with your fingers over and over. You want to provide a cool environment in which to do this. Cool is better than warm when it comes to babies with skin issues. We recommend using soft cotton clothing, and self-evidently, we want to clip the nails regularly so that the babies don't excoriate themselves and make their situation worse. With regard to bathing, when to do it is on an individual basis. Obviously, safety measures. Babies are slippery. We don't want them to fall. We must theoretically should clean the tub, with water before and after each use, and the water should be deep enough to cover the babies so that even their shoulders are well covered. Cleansers should be free of potential irritants such as fragrance, alcohol, essential oils, botanicals, including lavender, and hot detergents like sodium lauryl sulfate. A neutral or mildly acidic pH cleanser may be used, as we've discussed before. We want to maintain an adequately heated external environment so that we don't, the babies don't lose heat through convection. Neonates should immediately be covered with a towel and patted dry or almost dry. So we want to pat them, not rub them dry, and we want to keep them just a little bit moist, although we do want to make sure that all the intertriginous areas are well dried. And then we want to apply moisturizer head to toe for skin dryness prevention and management. Moisturizers, as we've said before, the moisturizers restore lipid levels and improve hydration, offering buffering capacity to normalize skin pH and maintain the skin microbiome. Apply a moisturizer head to toe daily, once daily for all infants, and more frequently for babies with itchy, flaking, fissured skin. Again, same thing with the container. Maintain good hygiene, single-use applicators. Products should contain well-tolerated preservatives and be free of common sensitizers, and moisturizer containing skin lipids such as ceramides may offer additional benefits. And I've experienced this myself, parents having issues with their children's skin or getting sensitized to some of the products that tout their organic ingredients. And if you look at the ingredients, they have multiple organic compounds, plant-based organic compounds, of which some babies can become sensitized to. Diaper care. While you're in there, evaluate the perineal area. It's your opportunity to do that, so you can get to perineal dermatitis early. Disposable diapers are preferred. Now, there's evidence to support that. However, if you have a parent who's very wed to cloth diapers or to the other versions of that, it's not worth picking a fight with them. They seem very committed to it. In case of diarrhea, obviously increased frequency of diaper changes are required. Use soft disposable towels or cotton balls, or even those water wipes, or wipes with warm water would be the preferred cleansing method. If you have dried stool on the skin, then use a cleanser with a physiologic pH. We should really avoid the wipes that were prevalent up until even now, but at least recently, that have more of a chemical ingredient, and they should be free from alcohol and fragrance. Barrier creams should be used on all neonates at every diaper change at the first sign of erythema or skin breakdown, and in the diaper derm prone babies, just prophylactically. And it's not important or not necessary to remove the barrier creams between diaper changes. And as I mentioned earlier, barrier creams containing plant extracts and or fragrance should be avoided. Risk factors, of course, for perineal dermatitis include frequent stooling, antibiotic use, malabsorption, opiate withdrawal, and abnormal rectal sphincter tone, and really avoid using powders in the diaper area. So just going back to ceramides, the function of ceramide-containing moisturizer. So ceramides are the lipids that help form the skin's barrier. They help skin retain moisture. They help protect the skin against environmental aggressors such as irritants and pollution. Formulations that contain ceramides mimic physiologic lipids, supporting homeostasis in improving the skin condition. And neonates and infants greatly benefit from frequent moisturizer use. And that's it. I want to thank everybody for listening. If you have any questions, you can submit them using the chat pane on the right-hand side of your screen. And additional questions you can submit to info@rbcconsultants.com. And I see Dr. Schachner has rejoined us.
Yes, thank you so much, Dr. Schachner and Dr. Leckman. Again, we want to thank our sponsor, CeraVe, for making this educational SkinChat webinar possible. So we do have some questions, and we do have a bit of time for questions from the audience. How much moisturizer is too much moisturizer?
You know, it's a great question. Really, it's both a quality and quantity question. Dr. Leckman made the point that the product should be pleasant to use. What's pleasant in Chicago in January may not be what's pleasant in Miami. So I tend to avoid the really thick, sticky emollients that might feel tacky to a baby. And might feel a little unpleasant to the parents as well. I like more the emollient, moisturizing emollient creams, especially in hot and humid weather. Quantity, well, the quantity, parents will ask that question, and Dr. Leckman again said something operative, and that is you don't want the baby slippery. I tell the parents that if they go to hug their child and the child flies up to the ceiling, they've probably overdone it. That they don't need a slippery baby. They just need enough to get a little bit of glistening on the skin surface. But you can't overdose on the emollient. But if your baby starts getting slippery, then you have a little bit too much.
Another question we have, any suggestion for drool rash on cheeks?
I'll leave this to Dr. Shackner.
So you want to avoid overreacting to the drool rash. You can use the frequent application of moisturizers, which will both give you a better barrier and protect. If there is a very mild degree of more chronic erythema, then you have a number of agents, both very, very low potency topical steroids, but also non-steroidal anti-inflammatory agents as well. The calcineurin inhibitors and the phosphodiesterase inhibitors, the PDIs in particular, have been approved down to several months of age. So that would be an option. But really good moisturization and reapplication of the moisturization probably would get the job done.
And at what age do you consider giving the first baby a bath?
It's a good question. I think a little bit of it depends on when the parent has removed the vernix. So I am seeing now more commonly with people leaving the vernix on for more than just a few hours, and we certainly encourage that. But once the vernix is cleaned off, I think the timing of when to bathe the baby isn't important. It should certainly be within the first couple of days of removing the vernix. But again, it's important what you use when you clean the baby. So obviously a gentle cleanser with an appropriate pH to not dry the skin.
What shampoo do you recommend for neonates?
In general, I recommend the same shampoo to use the cleanser as a shampoo. Typically, like a CeraVe infant wash is meant for both the scalp and the rest of the skin of the body.
Why are moisturizers important regarding the atopic march?
Well, it's a really key question. We know that moisturization, according to the Academy of Dermatology guidelines, will decrease the number and severity of flares and will increase the time between flares. If you accomplish that, then statistically, you're going to decrease the progression from a cutaneous atopic condition to a more systemic atopic condition, which can include reactive airway disease, GI symptoms, as well as sinus and nasal polyposis issues. So that's where the strong vote and the guidelines promote the use of moisturization to avoid advancing on the atopic march.
Why is it important to wear cotton rather than fleece clothing in infants, and of course, especially infants that have atopic dermatitis?
You know, I mentioned this earlier. So fleece really is, first of all, it's a synthetic product. It doesn't breathe particularly well. And so it concentrates heat and subsequently concentrates moisture. So as the baby perspires, as many babies do when they sleep, even at a young age, it can't permeate through the clothing and evaporate. And so it creates kind of a soupy, swampy, warm environment, which then exacerbates babies' atopic dermatitis if they're prone to that, but just irritates the skin in general.
To what age are ceramides useful in topical skincare?
Dr. Shackner?
I would say to my age and beyond. At every stage of life, you want to optimize your barrier function. The ceramides help optimize your barrier function and help you actually make your own physiological lipids. So there's no endpoint. And, you know, pediatric or geriatric skin both deserve to have as good barrier function as possible. So there is no senior date for stopping your ceramide-based moisturizers.
Well, that is all of the time that we have together this evening. So I would like to thank Dr. Lechman and Dr. Shackner for such a clinically insightful presentation and very practical. And I'd like to thank you all for joining us this evening. Have an excellent evening and happy holidays to everyone.
Happy holidays,
Bye.
everyone. Be well.
Happy holidays, everybody.